Hi, my name is Danielle, and this is my unit for case connections. I chose to do cases 1 and 2. So for case 1, a newborn girl appeared normal at birth, but then within 24 hours developed a series of symptoms. And the question is, which diagnostic test should be or would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? So the tests we have options for are blood glucose, urinary acids, serum fatty acids, and plasma glutamine. So I think that the best diagnostic test to distinguish between a urea cycle disorder and a disorder in beta oxidation would be blood glucose. Beta oxidation deficiency can result in hypoglycemia due to inability to support glucose synthesis. Therefore, blood glucose levels would be decreased in beta oxidation deficiency. As far as the urea cycle with blood glucose would show up as normal in a disorder of the urea cycle because dietary blood glucose is used for the urea cycle to ultimately produce PRPP synthetase. PRPP synthetase is used in purine synthesis, which ends in secretion of uric acid. Blood glucose levels would remain normal in a urea cycle disorder, and there would just be an elevation of the total body urates. So then the second diagnostic test is urinary acids, and urinary acids would show a deficiency in the urea cycle because the urea cycle takes free ammonium and through a series of processes forms uric acid. Urinary acids do not have an effect on beta oxidation, so this test would only be good to show a urea cycle disorder, not beta oxidation disorder. The third diagnostic test is glutamine, or plasma glutamine, and glutamine is a precursor of urea, and accumulation of glutamine would suggest a urea cycle disorder. Glutamine levels would not impact beta oxidation. So again, glutamine plasma levels only good for detecting urea cycle disorder. And then the fourth one is serum fatty acids. Beta oxidation oxidizes free fatty acids taken up by peripheral tissues, and an increase of serum fatty acids would indicate a deficiency in beta oxidation. A deficiency in beta oxidation would also negatively impact the urea cycle because ATP is required for the urea cycle because it's an anabolic process. And beta oxidation produces NADH and FADH2 to be oxidized in the ET electron transport chain to produce ATP. So the second part of case 1 is to determine the urea cycle enzyme that is most likely deficient and the urea cycle enzyme that is least likely to be impaired. So in this patient, the blood work showed elevated ammonia levels, elevated urine uric acid levels, and normal plasma citrulline levels. So I think the most likely urea enzyme to be deficient is ornithine carbamyl transferase. Ornithine carbamyl transferase deficiency would cause an increase in orotate because elevated orotic acid levels means there's an increased accumulation of carbamyl phosphate. This accumulation happens because carbamyl phosphate is used in pyrimidine synthesis as well as the urea cycle. So when carbamyl phosphate accumulates, it enters the pyrimidine synthesis to be used in synthesis of orotate. A deficiency in ornithine carbamyl transferase would result in a pool of carbamyl phosphate not being used and increasing orotic acid levels, which is what this patient showed. Ornithine carbamyl transferase deficiency would cause a decrease in blood citrulline levels, which this patient's citrulline levels are listed as normal, but the normal plasma citrulline levels are labeled as 12 to 55, and the patient is 10. So technically, the citrulline levels are slightly lowered, which indicates the effects of ornithine carbamyl transferase are starting to impact citrulline. If orotic acid levels are elevated, carbamyl phosphate levels are accumulating, which means the urea cycle enzymes carbamyl phosphate synthetase 1 is functioning properly. So I think carbamyl phosphate synthetase 1 is the least likely deficient enzyme because its deficiency would cause decreased levels of urine orotate, and the patient's urine orotate levels are markedly elevated. Okay, and then next I did case 2. So case 2 is a 4-day-old infant whose newborn screening demonstrated elevated levels of phenylalanine, and there was a presumptive diagnosis of phenylketonuria. The question is, as a consequence of this presentation, which amino acid may become essential? And the answer is tyrosine. Phenylketonuria is the result of a deficiency in phenylalanine hydroxylase. BH4 is a cofactor for phenylalanine hydroxylase and is also required for the metabolism of tyrosine metabolism. When phenylalanine hydroxylase is defective, tyrosine becomes an essential amino acid over phenylalanine. So then for part 2, what are the potential causes of the presentation of phenylketonuria? So potential causes are deficiency in phenylalanine hydroxylase, like I just explained. Also a defect in dihydrobiopterin reductase or dihydrobiopterin biosynthesis, or a deficiency in BH4. So then the last part of case 2 is how would you summarize the results of the tests for patient A and patient B? So patient A has an increase in phenylalanine levels after BH4 loading, and patient B has a decrease. So BH4 is a cofactor for phenylalanine hydroxylase and is needed for hydrolation of phenylalanine to produce tyrosine by phenylalanine hydroxylase. A patient with phenylketonuria is producing more tyrosine because it is now an essential amino acid due to the defectiveness of phenylalanine hydroxylase. Therefore, the patient is using more BH4 than normal. So patient A with the increase in phenylalanine, a slight increase, basically remains stable after BH4 loading. If BH4 loading occurs in a patient with phenylketonuria, phenylalanine metabolism is impaired and levels shouldn't change with the BH4 loading. The patient B has the decrease in phenylalanine levels, so that shows the addition of BH4 is increasing phenylalanine, so phenylalanine metabolism is working just fine. And that sums up my Unit 4 case connections. Looking forward to your feedback.